Now we're gonna start to make a little bit deep diving in oncology. Let's get started. Module 1, Basics 1. Do you know that 77 million deaths worldwide can be attributed to malignancy each year? Do you know that the interplay between the hereditary and environmental risk factors underlying the development of malignancy is becoming clearer? And at least 50% of malignancy cases are thought to be preventable. Cancer definition: it is a disease where cells lose normal growth regulation and proliferate abnormally from their normal counterparts and invade other tissues. And not a single disease, but a collection of multiple cellular abnormalities. Cancer cell behavior is differentiated from normal cells by 4 characteristics. First, clonality. Second, anaplesia. Third, autonomy. Fourth, metastasis. Definition of clonality. Clonality is one cell leads to proliferation of many malignant cells. Autonomy, which means growth is resistant to normal regulation. Anaplesia, which means cell differentiation is less or not at all coordinated. Metastasis, malignant cells disseminate and grow discontinuously to other parts of the body. Now we have 3 important and pivotal terms that we should talk about. First, benign, which means cells are not cancerous, local problems doesn't spread, most growth don't return when removed. For example, benign thymomas and acoustic neuromas. Malignant, which means cells are cancerous and cancerous cells can spread and invade other tissues. Metastasis, the process and outcome of malignant or cancerous cells spreading and invading other tissues. The hallmarks of cancer are clonality, autonomy, anaplesia, and metastasis. Autonomy, which means resistant to apoptosis, angiogenesis, and limitless replication, and self-sufficient growth signals, and insensitive to anti-growth signals. Okay, the abnormal proliferative growth behavior for the cells may be reversible with removal of the stimulus such as radiation or carcinogen. And when it comes to abnormal proliferative growth behavior, we should know some definitions such as hyperplasia, which means increase in the number of cells within an organ or tissue, hypertrophy, which means increase in the size of the cells within an organ or tissue, or atrophy, which means reduction of cell size or number. So hyperplasia is dealing with number of the cells, hypertrophy is dealing with the size of the cells, and atrophy is dealing with the size and number. And we should know the difference between the definition of carcinoma in situ and malignant neoplasm. For the carcinoma in situ, it is a dysplastic cells involve the entire epithelial thickness. Okay. For the carcinoma in situ, it is a dysplastic cells involve the entire epithelial thickness and push against the basement membrane. Equivalent term to high-grade dysplasia. It could be considered as pre-malignant, non-malignant, non-invasive, because the basement membrane is still intact. But when it comes to malignant neoplasm, dysplastic cells have broken past the basement membrane, and cells are invasive as the basement membrane is no longer intact. In this diagram, we can demonstrate the difference between normal and tumor cells. And here, the mild dysplasia, and moderate dysplasia, and severe dysplasia. And lastly, tumor cells. When it comes to the epithelial surface and basement membrane, we should see normal squamous epithelium. Its appearance should be like that. And when it comes to dysplasia, here mild dysplasia and moderate dysplasia, and here severe dysplasia. Finally, in the stage of carcinoma in situ, the dysplastic cells are pushing to the basement membrane, but the basement membrane is still intact. Finally, if the basement membrane is broken down, it becomes a malignant neoplasm or invasive cancer. Genes involved in cancers fall into three main categories. First are oncogenes, second, DNA repair genes, third, tumor suppressor genes. When it comes to oncogenes, are mutated genes that cause cells to grow out of control and can lead to cancer. Proto-oncogenes are normal genes that control cell growth, but if they become mutated, they can turn into oncogenes. Proto-oncogenes and oncogenes act like on and off switches. When a proto-oncogene is switched on, it is telling a cell to grow or divide, but oncogenes are always switched on, so its cells grow out of control. Second gene is tumor suppressor genes. Slow cell growth and division, repair mistakes in DNA, and tell cells when to die, a normal process called apoptosis or programmed cell death. Protect us against cancer. Working properly when they are switched on, prevent cells from dividing too quickly, but when these genes are mutated, they are turned off. This causes cells to grow out of control, which can lead to cancer. DNA repair genes fix mistakes in other genes that can happen when DNA is copied. When DNA repair genes are mutated, they can't fix mistakes in oncogenes and tumor suppressor genes. This can lead to cancer. Here a diagram which demonstrates the transition between proto-oncogene to oncogene. Normal genes regulate cell growth. As you can see, here no mutation and no cancer. Second, first mutation leads to accelerated cell division because the proto-oncogene becomes oncogene. The result of that, the possibility of having cancer will be increased. The second diagram illustrates the importance of tumor suppressor genes. Here, as you can see, normal genes regulate cell growth without any mutation, and the core is away from cancer. Here, as you can see, first mutation, which means a susceptible carrier. In the first mutation, the proto-oncogene becomes active oncogene, as you can see, but we still have tumor suppressor genes, which acts like a cord break. The second mutation or loss leads to cancer because we lost the effect of the tumor suppressor genes or the cord breaks. No breaks. As a result of that, we have a recipe of disaster and the person will have cancer. Now we're gonna discuss the two-hit hypothesis. The first example, normal patient with no genetic predisposition and have tumor suppressor gene with no mutation inside its two DNA strands. 0 hits at birth. Both genes are normal at birth and the normal phenotype. If this person during his lifetime has 1 hit, as you can see here, 1 hit during lifetime, 1 allele damaged due to carcinogenic mechanism during lifetime, but the person still has normal phenotype. But the second example, if the patient with genetic predisposition, tumor suppressor gene here is normal and the second is mutated. First hit at birth, 1 allele damaged by loss of function mutation at birth with normal phenotype. And if the person has 1 hit, as you can see here, for the normal tumor suppressor gene allele, the second hit leads to cancer. Second allele damaged by carcinogenic mechanism during lifetime and abnormal phenotype as a development of cancer. Carcinogens are substances which induce malignancy by altering normal cellular genetics. They can be classified into 3 general categories. First, chemicals such as cigarette smoke and asbestos. Radiation include ultraviolet radiation from the sun and radiation therapy. Viruses act differently by introducing new genetic material to a cell altering existing genetic material, leading to recombination which may be malignant. Cancer grading and staging. Systems for describing tumor grade can differ depending on the type of cancer, but most tumors are graded as X, 1, 2, 3, or 4. The grade of cancer depends on what the cells look like under microscope. In general, a lower grade indicates a slower growing cancer, and a higher grade indicates a faster growing one. The grading system that's usually used is as follows. Grade X, grade cannot be assessed, undetermined grade. Grade 1, well differentiated, low grade, cancer cells that resemble normal cells and are not growing rapidly. Grade 2, moderately differentiated, intermediate grade, and cancer cells that don't look like normal cells and are growing faster than normal cells. Grade 3, poorly differentiated, high grade, cancer cells that look abnormal and may grow or spread more aggressively. Grade 4, undifferentiated and high grade. And the tumor grades, as you can see in this diagram, grade 1, well differentiated, grade 2, moderately differentiated, grade 3, poorly differentiated, and grade 4, undifferentiated. When it comes to cancer staging, we have two main cancer staging systems. First one is number staging system, and second one is TNM system. First, number staging system. Number staging system contains stage 0, the cancer is where it started, in situ, and hasn't spread. Stage 1, the cancer is small and hasn't spread anywhere else. Stage 2, the cancer has grown but hasn't spread. Stage 3, the cancer is larger and may have spread to the surrounding tissue and or the lymph nodes, glands, part of the immune system. Finally, stage 4, the cancer has spread from where it started to at least one other body organ, also known as secondary or metastatic cancer. TNM staging system. The TNM system uses letters and numbers to describe the cancer. This system is used in different ways depending on the kind of cancer. For the TNM system, T describes the size of the tumor with numbers 1 to 4, 1 for small and 4 for large. N stands for lymph nodes with numbers 0 to 3. 0 means no lymph nodes have cancer, and 3 means many do. M stands for metastasis, or whether the cancer has spread to another part of the body, with numbers 0 or 1. 0 means it has not spread, and 1. TNM staging provides a universal classification of tumor description. Tumor, T. Definition: extent of local primary tumor growth. TIS refers to carcinoma in situ, and T 1, 2, 3, 4 represent the size and extent of local primary tumor, and T0 refers to no primary tumor. Node, or symbol N, absence or presence of malignancy in the regional lymph nodes. N0 refers to absent nodal malignancy. N1, 2, 3 represents the extent of nodal involvement. Metastasis, or M, absence or presence of metastasis. M0 represents no metastasis. M1 represents metastasis. Thank you.